Well, welcome everybody. Hope everyone's having a nice Friday and ready for the weekend soon. Just gonna give it another minute so everyone can get logged on here. I think we have a few more coming on here, so just give me a second. All right, we'll go ahead and get started. As other people come on, I'll just admit them into the Zoom session. And so thanks again, Dr. Nino, for joining us today. Bright and early in San Diego.
It is indeed.
So again, welcome to my family violence class. And so for everyone, as we discussed, this is Dr. Shalyn Nino. She's a child abuse pediatrician at the Rades Children's Hospital in San Diego. She's also an assistant clinical professor of pediatrics at UC San Diego School of Medicine. And so if you remember, last week, we talked to Lily Gray, who is the director of the Teal House here in Statesboro. And she kind of gave us an idea of the services that we provide to sexual abuse survivors here in Statesboro from the service provider point of view. And today we'll talk a little bit more about physical and sexual abuse, especially as it pertains to children from the medical side. And so I think this is really great because we know a lot about sort of service provision, some of the barriers and challenges to providing services for children of sexual abuse. And now kind of getting a little bit more into the medical side in terms of examination of children who have been abused by physical or sexual violence, making that identification, and then again, providing services for those who need it. And so, Dr. Nino, thanks again for taking time. And I think you're going to present. So I'm going to make you a co-host here. And so do you want to introduce yourself a little bit and say how you got into this line of work?
You did such a good job. He made me sound smarter than I am. So people always ask me how I got into child abuse, and really it chose me more than I chose it, which most of us who work in this field kind of feel that way. My background is I was a neonatal intensive care nurse in my former life, and I was a traveler, and I kind of went up and down the East Coast. I decided at one point that I wanted to go to medical school. Bad decision. And so I applied to medical school and got in. And when I went to medical school, I thought, I'm not going to do pediatrics, been there, done that. I really want to do pathology. So I loved pathology, everything about it, except it tends to attract a certain personality that doesn't like people. So I would be there all day and no one would speak to me. So at some point I was like, I don't know if I can sit in silence all day long. I think I have entirely too much personality for this field. I guess I'll just do pediatrics. So I went into pediatrics. I love kids. I've worked with them before. And what's nice about kids is they don't generally tend to cause their problems the way adults do. So it's less frustrating for me. As I was going through pediatrics, I had this run of children who were physically abused. I had this little 2-year-old who had a 15 by 19 centimeter pseudocyst, which is a big cyst inside his abdomen, huge one, and some pelvic rim fractures that were probably from being stomped on. And CPS was going to send him home to his family. And they had domestic violence events in the hospital. And I was pretty sure that they were the perpetrators of this child's injuries. So I told the social worker, I'm just gonna, chain myself to this kid's bed or make up reasons that he has to stay in the hospital. He cannot go home with these people. It's not safe. And she said, well, why don't you get the child abuse doctor involved? And I was like, the who? And so I learned about this specialty and I was like, that is what I want to do. It's a little bit of a cross between pathology and pediatrics in that it's kind of solving the puzzle. So my job is to help other professionals determine whether abuse or neglect is present in any given case. And so when we talk about physical abuse stuff, that's me determining mechanisms of injury. Does this history fit this child's injury? Those types of things. And then for sexual abuse cases, in large part, that's me helping to determine whether or not a history provided by a child is consistent with a diagnosis of sexual abuse. So I help law enforcement, I help child welfare or child protective services. I help other physicians determine whether or not this is present. And then I help speak for the child in court cases. So I've testified as an expert witness in 98 cases in the 10 years that I've been doing this. So I go to court fairly frequently on both the civil side, which is what Children and Family Court does, and then the criminal side, if they press charges against the perpetrators of the abuse. What I want to talk to you guys today is how, as a pediatrician, we help to identify abuse, kind of some of the barriers with regard to how the population at large recognizes abuse and the issues that we have with regard to people believing that children are abused or neglected, because that's really what we see, especially when we get into the court realm. There really isn't this debate that abuse happens in the medical realm. That's just specifically related to court, where there is this perception that there's a debate about whether abuse happens, especially like abusive head trauma, formerly known as shaken baby syndrome. That's really not debated at all within the medical community. It's just kind of a court issue. So why do we have these issues? So I'm going to share my screen here a little bit. If you guys have any questions during the course of the presentation, please do not hesitate to stop me. The whole purpose of this is for you to get information that you need to do your jobs effectively, and I'm happy to entertain any questions at any point.
Yeah, and I'll be monitoring the chat box too. So if you have anything that you want to throw in there, I'll have that up as well.
Perfect. Thank you, Dr. Pasek. Okay, so the first thing you need to understand is how big the problem of child abuse is. About 7.5 million children are referred to Child Protective Services nationwide every year. About 3.5 million children receive investigations, meaning less than half of those kids are assigned to a CPS worker to investigate those allegations of child abuse and neglect. 674,000 or so are confirmed by CPS to be victims of abuse. However, we know that this is probably a gross underestimation of the children who are abused and neglected. This is for a couple of reasons. One, if we do anonymous surveys of parents or guardians, they will report abuse such as kicking, burning, biting, punching, all manner of badness to their children at really significantly higher rates of what we are confirming. So rates of about 3.6 million children a year. Part of the issue with CPS systems nationwide is that they're voluntary services. So if you don't open your door or you don't cooperate with CPS, there's really nothing that they can do. And oftentimes those cases are closed as unfounded when in actuality that child may be a victim of abuse or neglect. The other issue is that we know CPS systems are overworked and underpaid. They just do not have enough investigators to handle the caseloads that they have. So there's this issue with triage. So they triage cases out, but just because those cases get triaged out doesn't mean that those cases do not involve abuse or neglect. So at baseline, they cannot investigate all of the cases that have suspicions for abuse or neglect. And some of those cases that get triaged out are probably actual abuse cases. And some of the cases that are not confirmed as abuse or neglect also probably represent abuse cases. The other issue is that in order to have an investigation for CPS, somebody has to report it. But when we talk about the epidemiology and rates of abuse or neglect, it's really difficult for us to compare like apples to oranges. So really it's all about perspective. The best way for me to explain to lay people how prevalent child abuse or neglect is to look at death rates. So every day, 5 children die secondary to abuse or neglect. This works out to be just around 2,000 children a year. When we look at all-cause mortality for children, we see that this is a rate that's twice as many as children who die of cancer, more than twice as many children who die from drownings, and almost 3 times as many children who die in motor vehicle accidents. All of these things that we have national campaigns against. So children are dying at a higher rate from abuse or neglect. It's an epidemic, but it's an epidemic that we as humans really don't want to recognize and acknowledge. There are multiple risk factors for perpetration of abuse, the largest one being substance abuse of caregivers. So that's present in somewhere around 60 to 80% of the cases that I see. So if you are under the influence of drugs or alcohol, you probably can't supervise children in a reasonable way, nor can you respond to emergencies in a protective fashion. Also, people who are under the influence can barely take care of themselves, so aren't really taking care of children in a great way. And then there's other violence issues related to substance abuse in a household, which we'll get to later on. Domestic violence is probably the most traumatizing thing that can happen to a child during their lifetime. So this is one of those ACEs that we talk about. And I'm sure you've talked about ACEs a lot in your roles, but we know that children who have 6 or more ACEs have a lifespan that is 20 years less than children who have a less number of ACEs. So witnessing domestic violence is one of those ACEs. It's also a distinct form of psychological maltreatment. Psychological maltreatment being a state in which children are living in perpetual fear. So these are children who are constantly waiting for the other shoe to drop. When you live in that perpetual state of fear, you have a lot of stress hormones floating around, such as cortisol, and all of those fight or flight hormones. And what happens is that causes really profound issues from a physical health standpoint. So we know that leads to high blood pressure, diabetes, heart disease, all of those things later on. So not only is psychological maltreatment a problem from a mental health standpoint, it's also a problem from a physical health standpoint. So witnessing domestic violence, terrible thing for kids. Also, when children are living in domestic violence homes, we know that they may become collateral damage. So they position themselves in between the perpetrator and their intended target and may become injured in that way. Also, people who are willing to cause harm to one household member are very likely to treat other household members in the same fashion. Lack of education is a really significant problem from the perspective of, are we giving tools to parents to help them understand how children are supposed to behave? So children basically are placed on this earth to punish you for everything wrong you have ever done in your life. So those of you who want children, get right with your moms now, because karma is powerful. I have 2 children and they teach me every day how to be humble and patient. But when you don't have appropriate expectations for children, these little humans that are annoying at baseline become even that much more frustrating. And that frustration level is what leads people to act out in ways that are potentially harmful. So what do I mean by this? So if you don't know that kids are going to cry for hours at a time and there's nothing that you can do about it, that crying is going to be particularly frustrating, is going to make you respond in a particularly harmful way. If you don't know that when you start potty training, those kids are going to have toileting accidents for a pretty prolonged period of time before they're dry, then every time they have an accident, you're going to be frustrated. If you don't know that kids are just going to refuse food sometimes, that can also be particularly frustrating. So it's really important for us as professionals who work in pediatrics to help parents have appropriate expectations for children's behaviors to reduce some of that frustration level. And then, of course, if you have profound mental health issues and you can't take care of yourself, you're very unlikely to be able to take care of another small human being. Some other risk factors for abuse and neglect are living in a single parent household, family stress or isolation, think COVID. Our numbers of abuse and neglect cases have gone through the roof during the era of COVID, even as COVID has progressed. So one would think that now that kids are back in school and things are pseudo returning to normal, our rates would go down, but in fact, they're going up. Our rates are up 52% overall over last year, and at points during the pandemic, we're up more than 120% prior to COVID hitting. Anytime you have a child who has chronic medical conditions such as low birth weight, any sort of disability, so cerebral palsy, ADHD, autism spectrum disorder, those children are at twice the risk of being abused or neglected than their same aged peers. The biggest risk factor for death related to abuse or neglect is living in a household in which there's an unrelated caregiver. So mom and her boyfriend, dad and his girlfriend. Anytime you live in that type of household, you are 50 times more likely to die from abuse or neglect than if you live with two biologic parents. So it's a really significant risk factor that we see. That being said, there truly is no singular type of family or social situation that is immune from abuse or neglect issues. And that's really important for us who work in child protection to understand, because we know that there's significant bias with regard to child abuse investigations and substantiations. So if you live in an intact white family, you are less likely to be reported for abuse, you are less likely to be recognized as being a victim of abuse, and you are less likely to enter foster care, as opposed to if you come from a family of color or a broken family. So it's really imperative for us to recognize these biases so that we don't overlook abuse in those communities where abuse is happening, and we don't overestimate the proportionality of abuse in some of our underserved communities. One of the biggest issues that I see with regard to disbelief in abuse or neglect is what we call the false attribution error. This is our natural human tendency to over-attribute personality traits as drivers of behavior and to under-attribute the role that environmental factors have in making our behavior happen. So what does that mean? What we think is that nice people do nice things and bad people do bad things. And those of you who haven't seen The Wild and Wonderful Whites of West Virginia, I highly recommend. It's an interesting social dynamic that's going on there. The reality is that nice people can behave in ways that are not representative of who they are as people under the right circumstances. So when people are chronically fatigued, or when there's financial strain, or when there's kids who are crying incessantly, these types of things can lead to significant frustration, and people will behave in ways that are not indicative of who they are as people. So nice people can behave in ways that don't represent who they are. I truly do not believe that most people wake up in the morning and say, I'm going to harm my child today. I think that there's something going on in their life that they don't recognize their responses to, and then they act out in a spur of the moment decision that causes harm to children. These aren't inherently bad people. And that's what's important for us to understand, so that we can have some empathy for these families, and also so that we can mitigate these risk factors, because mitigation of these risk factors is really what's going to help keep kids safe. We can't keep people from being frustrated, but we can give them tools to help reduce some of that frustration. So if there is this financial problem happening in the home, how can we provide services to you to mitigate some of that, so that you don't end up in a place where your emotional reserve is gone and you end up harming your child? It's also really important for everyone to remember that how nice or appropriate, I hate that word, when people call in consults to me and they're like, I don't really have that much concern because this family is so appropriate. Well, what does appropriate mean, really? None of that determines the likelihood that a child is being abused or neglected. Again, because nice people can do bad things. How bonded, attached, or unafraid a child is of their caregiver does not indicate the likelihood that that child is being abused or neglected. Kids don't understand that this is not a normal situation. They don't know that this doesn't happen in every single household and to every single kid. This is the person that they love and they trust and they depend on to meet their basic needs. So they're not going to be afraid of the perpetrator. And that's a common myth that we have as humans, that if kids are being abused, they're going to act like they're abused, and they actually do not. Even when I have children who are admitted to the hospital with such severe injury that they are in the ICU or are near death, the first person that they're asking for is the person that put them there, because usually that person is somebody that's loved or trusted by them. Some red flags that we see that are under-identified, not only in medicine, but kind of in the society at large, that is really important for you guys to understand, is what we call sentinel injuries. Sentinel injuries are specific to non-ambulatory infants. So these are infants who are not walking, not cruising, cruising being pulling to stand and walking while holding onto furniture. Sentinel injuries are relatively minor injuries in pre-cruising infants that end up being harbingers for future, more serious abuse. We know that this happens because when we see kids who come in with fatal or near fatal abuse, we can look back in their medical records and see that they have had previous injury that was not recognized by providers as important, or is downplayed in its significance, and really represents a missed opportunity for protection of these kids. Types of sentinel injuries that we see, far and away, bruising is the most common. In 80% of cases, it's a child who presents, an infant specifically, who presents to a physician for any number of concerns. They see the bruising, they document the bruising, but then they don't do anything about it because they don't recognize that this is related to actual trauma. Other types of sentinel injuries are subconjunctival hemorrhages, which is bruising in the whites of your eyes. Intraoral injuries, specifically torn frenulums. Frenula are those pieces of skin that attach your lips to your gums and the tongue to the bottom of your mouth. So anytime we see infants with intraoral injuries, we are really concerned for inflicted trauma. Ear bruising is highly specific to abusive injury. And then kids who aren't moving don't get fractures, and they don't get nursemaids' elbows. So anytime we see those things, we become very concerned as well. Bruising is an important topic because they are the most common abusive injury. Granted, they're also the most common accidental injury, which is why they're the most common sign of abuse to be missed. There are many reasons that bruises are important. One is because, again, they're these high-risk prognostic indicators for future more severe harm. And we know that when we don't recognize bruising as a sign of abuse, it's not only a medical shortcoming, but it's also a social and legal shortcoming that leads to poor outcomes. It's very difficult for me to help a judge understand that this singular bruise on this 2-month-old infant is abusive and may mean that this child is going to be killed later on in life, which is actually what happens. Anytime I see a kid who comes in with fatal abusive injury, I can look back and see that they've had a bruise that somebody has overlooked. Why are bruises overlooked? Well, because they're the most common injury in children in general, right? In ambulatory kids, so kids who are walking, running, climbing, jumping, bruises are common and often innocuous injuries. There are 2 things that can change the way we think about bruises. One of those is the age of the child, and the second is the location of the bruise. Our mantra in child abuse is, if you're not old enough to cruise, you're not old enough to bruise. So I'm going to put up some bruising pictures here. So if any of you are triggered by any of this, feel free to not look at the screen. But in this picture, this is a little 4-month-old baby who was slapped for crying. You can see that there's bruising kind of right in front of his ear, and there's these parallel linear lines that look almost like scratch marks. Those are not scratch marks, those are actual petechial bruising, so that's pinpoint broken blood vessels. That happens when there's a high velocity impact to a child's skin. When that takes place where the object contacts the skin, it will not bruise. It forces blood out from underneath the object into the adjacent capillaries where they become overfull and burst, and creates kind of like a negative imprint. So this is classic hand slap pattern that we see. And so if you're not old enough to cruise, you're not old enough to bruise because you are not generating enough force independently to cause bruising to yourself. It is a really common myth that infants bruise real easily, and that's actually false. Bruising is a function of force applied to a vessel wall such that the vessel wall is crushed and it fails, and then blood seeps out into the adjacent subcutaneous tissues. If you think to physics class, I hate physics class, but it does come in helpful to my life. Force equals mass times acceleration. Babies do not have a lot of mass. And so the only time they can generate enough force to cause this type of injury is once they start to have acceleration. And that acceleration comes when they start to ambulate. So that's when they're starting to have that forward momentum. When you're walking, running, climbing, jumping, all of those things will increase the amount of force that happens when you have your impact trauma, which leads to those crush injuries. Infants cannot generate enough force themselves to cause this type of vessel injury. What are they doing? They're just laying there, right? Maybe they roll over. Rolling over doesn't cause you injury. Maybe they're crawling. That also doesn't cause this type of injury. They also have a high resistance to bruising, because resistance to bruising is a function of the elasticity of the tissues. So think collagen. Babies have a high proportion of collagen, not only in their skin itself, but also in the vessel walls. When you get old like me, you lose your collagen, which means you get wrinkles. And then you tend to bruise more easily because your blood vessel walls are not as elastic. They also have a really high proportion of subcutaneous fat per body area. So they have a lot of cushion. That cushion will resist that crush injury to the vessel wall. So infants bruise rarely. That is the truth of the matter. Anytime we see unexplained bruising in a non-mobile infant, that predicts future injuries, some of which may be fatal to the child. When we talk about ambulatory children, there are also types of bruising that make us more concerned than others. Kids bruise all of the time. That's just a fact. But kids bruise in very predictable ways. One, they tend to have forward momentum. So most of the bruising that we see on children are in bony prominences on the front part of their body because they're running, jumping, climbing, and they fall face first, right? So anything from the knees down is really fair game. You get bruises there all the time. Palms of the hands, bony forearms, foreheads, black eyes, all of those things are pretty common in kids. There are places that are relatively protected and places that have more elasticity that resist bruising. Those are the genitals, the inner thighs, the buttocks, backs of the thighs, and the ears. Anytime we see injuries in these locations, it raises our suspicion for the possibility of inflicted trauma. That does not mean that bruises in these locations are inevitably abusive. That's not the case. But when we see bruises in these locations, we have to raise our suspicion so that we don't miss those signs of abuse. Here's some common spanking injury. Bruising on the buttocks is very, very uncommon. We see it frequently in spanking injury. The picture on the left, you can see some red loops, and that's caused by any sort of flexible object being bent over itself. So cords, ropes, belts, those types of things. The picture on the right is hand slap pattern. On the right buttock, you can see that kind of negative imprint of the hand. And then you can see parallel lines on either side of the gluteal cleft or butt crack. That's classic spanking injury because when kids get spanked, it hurts. So they clench their butt cheeks together. That pulls that skin into the gluteal cleft and will cause sparing there. So the bruising looks like there's parallel lines on either side of the butt crack. This is typical hand slap injury. Again, you can see that negative imprint pattern with the linear marks on this little kiddo on the right. On this kiddo on the left, you can see the pinpoint broken blood vessels. This is that petechial injury that we're talking about, and it wraps around body planes. So the only way you can get impact trauma to multiple body planes is to have multiple separate impacts, or to be impacted by some sort of flexible object that wraps around body planes, like belts, hands, that type of thing. And so this little kiddo said that he was slapped by his stepmom, and this injury is consistent with that. Here's some belt buckle injury. What's really interesting about patterned injury is you can see these are two different types of patterns. These are two separate belt buckles, same child. When we have these patterned injuries, and this is just outline of that belt buckle. So this is those pinpoint broken blood vessels doing that negative imprint thing again. I will have investigators go out and find me the implement. I'll say, go get me all of the belts, and I can match this implement to the pattern, provided that the pattern is fresh. Sometimes, as well, all the time, as bruising age, it kind of spreads out and then it can distort the pattern, but we can get pretty close with the implement when we have patterned injury like this.
Can you also, Shalyn, can you date that as well a little bit? Like, can you say that this bruise is like, probably over a week old? And do you often see bruising of various ages on kids? Like, here's a bruise that was like yesterday, and here's one that was 2 weeks ago. And
that's a really good question. And the answer to that is no. So we cannot date bruising. If I could date bruising, I would be rich, because then I could say this happened at 3 p.m. on Tuesday. Who was the kid with at 3 p.m. on Tuesday? I cannot date bruising. There's a couple of reasons for that. We've done extensive studies looking at how bruising appears, and really they age very, very differently. So what we can say is that a yellow bruise is at minimum 18 hours old. But if I have a purple bruise next to a yellow bruise, that does not mean that those bruises did not happen at the same time, because they can age at different rates. And so bruising appearance is dependent on a whole bunch of things, like how much force was used to cause that bruise. So therefore, what level of depth of tissue are you injuring? How long is it going to take from that blood to get from that blood vessel to the surface of the skin to cause that visible sign of bruising? How much subcutaneous tissue is there? Is the skin loose or tight in that location? So there's a whole bunch of things that play into whether or not bruising ages in a specific way, and it's very unpredictable. So if I have a children with a whole bunch of bruises of different colors, all I will say is the kids got bruises of different colors. I can't even say that those are different ages. What we can say is most typically bruising will dissipate within a week. So with the exception of these petechiae, those pinpoint broken blood vessels, because those are small little capillary bruises, those tend to go away within hours to days. So I wouldn't expect to see that bruising beyond 3 or 4 days or so, but that's kind of an inexact science. Really, really good question, because people ask me to do that all of the time. If I could do that, law enforcement would like me more than they do. This is loop marks, so those flexible objects that we talked about before. The one on the, well, they're both belt marks. So you can see the belt was kind of looped over itself. We see this a lot with like charging cords for cell phones or iPads, electrical cords. Nobody has a telephone cord anymore, but ropes, all of those types of things. So when you have that flexible object, it will cause this typical loop shape pattern. This is diagnostic of physical abuse. There's really no accidental way that you can get this type of injury. The loop pattern on the left is the belt folded over on itself. This loop pattern on the right is actually the end of the belt where you would like fit it through the buckle. The only reason I know that is because this child had linear belt mark patterns on his back that ended with this loop on his arm. So he was standing with his back to the perpetrator who was whipping him with the belt, and the entire length of the belt pattern was on the back of him. Again, with pattern bruising, I can usually say what type of implement caused this injury. In this case, it was one of those belts that had like the metal grommets around where the prongs go in the buckle. And so we were able to say, yes, this bruising pattern is consistent with this implement that the child said caused the injury. Strangulation injury is really uncommon. Strangulation is a very common form of violence, not only in sexual assault cases, but also in physical abuse cases of children. It's a control issue. So perpetrators who use strangulation as a form of discipline will do that across multiple realms. So they'll do that with their intimate partners, they'll do it with their children, and it's a form of control. Strangulation is highly lethal. Clearly, it's the only act of violence where you actually have to actively stop killing somebody. If you continue with the strangulation event, that person will die. It's inevitable. So it's the only act of violence where you actually control whether or not you keep killing somebody versus allowing them to live. And that's where that power dynamic comes in. When we see strangulation injury, it's caused by traction on the skin. So when people cause this type of injury on the neck, what they do is they grab and they squeeze, and that squeezing causes the blood vessels underneath where the fingers are to kind of push that blood out into where the knuckles are. And you can see this like linear pattern, that's where the knuckles are. It's also when you grab a person and you pull on their skin, think like a hickey. A hickey is a traction injury, it's pulling the skin forward. This is pulling the skin down or to the side. It will cause these pinpoint broken blood vessels in this traction type event. This is suffocation injury. It also causes petechiae, but for a very different reason. So just like with strangulation and those pinpoint broken blood vessels, this is caused by increased intrathoracic pressure. So when a child's mouth and nose are occluded and they're attempting to breathe against a closed circuit, it causes a lot of pressure inside their chest, which will not allow blood to drain from the vessels of the head and neck. It becomes overfull and then they burst. And it bursts in the pattern of the facial vein. And so the facial vein supplies periorbitally, so around the eyes. We'll see these pinpoint broken blood vessels around the eyes, and it supplies behind the ears. So we'll see these pinpoint broken blood vessels behind the ears in these smothering or suffocation events. In smothering, where a person places an object underneath the child, over top of the child's airway, what will frequently happen, especially if the child is mobile, is they will try to unocclude their airway. So they will move their head side to side. When they do that, it causes abrasions around their nostrils and very frequently on the ala, which is the tip of the nose. So I have seen it where the entire tip of the nose has abrasion injury. The skin is removed because the child is trying so violently to unocclude their airway and will rub themselves raw. This is classic squeeze injury. So again, those pinpoint broken blood vessels, and this is caused by force when you do that squeezing, and you'll see some of these parallel linear lines, and that's from where knuckles are, and in between fingers is where we see this kind of crush injury. Very common in babies that we see this. Families will offer all sorts of reasons for why children have bruises, like a toy hit them, the dog did it, the homicidal 2-year-old in the household did it, but all of those things are really not likely to cause injury to children. Do 2-year-olds use too much force when they kiss and hug on their siblings? Absolutely, but they don't cause injury to kids. So there's a lot of histories that we know that don't cause injury that makes it more likely than not this is related to inflicted trauma. These are those subconjunctival hemorrhages I was talking about, so bleeding in the whites of the eyes. In infants, they cannot independently generate enough intrathoracic pressure to cause these. So pertussis is the only, which is whooping cough. It's the only medical way that kids can get this because that causes paroxysmal coughing. So they cough and cough and cough and cough and cough and cannot breathe. Otherwise, they can't independently generate this force. Almost always it's related to direct blunt force trauma to the globe itself. So this kiddo on the left had inflicted burn injury, but dad eventually confessed that he poked her in the eyes prior to that injury, and that's what led to her subconjunctival hemorrhage. This kiddo, we think, had a smothering event leading to his subconjunctival hemorrhage on the right. And this is that intraoral injury that I was talking about. This is a torn sublingual frenulum. These tend to bleed pretty profoundly because there's a lot of blood vessels in your mouth, and then the blood mixes with saliva, so it like doubles or triples the normal volume. So parents will say there was a ton of blood coming from this kid's mouth. A lot of times they'll offer that it was spontaneous combustion, meaning I don't know what happened, he just started to bleed from the mouth. That isn't an accurate history. This is almost always something being shoved into a child's mouth. So when babies cry, their tongue goes to the roof of their mouth. People get frustrated. They try to shove in bottles, pacifiers, spoons, you name it, and it will push the tongue back down towards the back of the throat and stretch this frenulum that attaches it to the floor of the mouth and cause it to be injured. And here's that ear injury we were talking about. So highly specific to inflicted trauma. It's usually pinching, pulling, or twisting of the ear. Impact injury, so being struck on the side of the ear, can sometimes cause this, but it's very rare. The reason for that is that ears are highly avascular, meaning they don't have a lot of blood supply. They're collagen. Collagen doesn't need a lot of blood supply, so it takes a lot of force to cause this type of bruising to the ears. They're also relatively protected because they're floppy, and if you impact the side of your head, you are more likely to get injury on bony prominences like your temple or your cheekbone than you are to get injury to your ear. Also, if you impact the side of your body, you're protected by your shoulder. So we don't see this commonly in impact injury at all. And then finally, some things that we see are what we call traumatic alopecia or forceful hair pulling. We can tell this happens as opposed to some sort of medical reason for hair loss, because in the patches, you will see broken hairs or even long hairs, because when you grab a child's hair and pull forcefully, you don't apply the same level of force to every single hair. So some of those hairs are unaffected. Traumatic alopecia can be pretty profound. So what happens is if pulled hard enough, it will cause an internal scalping. So the scalp will be lifted off of the skull itself and will cause subgaleal hemorrhage. Subgaleal hemorrhage can actually lead to exsanguination of the child because it's such a large potential space. You can see this kid has what appears to be black eyes. So you might think that's related to direct impact to the eye. It's not. It's actually blood settling by gravity from all of this blood that's up underneath her scalp, kind of settling by gravity down. And you can see how much swelling there is on the top of her head, which is why she's got these like shiny patches. So these are all things that we look for when we're looking for inflicted injury to kids. If you ever recognize these types of injuries, no matter what you're doing, whether you're babysitting or you're with your cousins or what have you, these are things that we get very worried about and warrant people calling in reports. So briefly, I want to talk about drug endangered children because this is a significant issue that is going up over time. Since 2009, mortality related to children from illicit opioids has increased 268%. And we know that there's a significant increase in toddler ingestion of marijuana products, any sort of cannabinoid, since there has been this push to legalize marijuana. Here at Rady Children's, we keep track of our common drugs of abuse when we see them in children. And so these are all children, no adults. This top line is our rate of cannabis ingestion in children. And you can see that it has been steadily on the rise since 2015. The opiate line is in white, but that's a little bit misleading because when we break it down by type of opiate, you can see that our fentanyl ingestions have gone through the roof. So most illegal opiates now are all fentanyl, so they're counterfeit. We don't see a whole lot of oxys or other sorts of narcotics as opposed to everything being laced with fentanyl nowadays, especially in San Diego County, because we're right on the border of Mexico. It is cheaper to get fentanyl and to counterfeit prescription drugs and sell them as the prescription drugs, which bring in a higher price point than to actually obtain the prescription drugs for sale. Fentanyl is 100 times more potent than morphine, so it causes really significant rates of fatalities. Cannabis is also not benign. Most people think that it's a relatively benign drug, except when you're a child. So when you're a child and you ingest, gummies that your parents leave around, it will cause seizures and respiratory arrest. So we have lots of children who end up intubated because of their cannabis ingestions. So most of our fatalities or near fatalities are related to marijuana products or fentanyl. Some other hazards when there's drug abuse in the household: lack of supervision. We see lots of kids falling out windows, lots of kids drowning, because when you're high, you aren't really watching your kids or taking care of them appropriately. So there's a lot of lack of supervision injuries. If you have one sort of chemical in the household that a child can get a hold of, you are likely to have other sorts of chemicals. We don't see a lot of manufacturing of methamphetamines anymore in this country. It's cheaper to import methamphetamines, but we do see extraction of THC from marijuana leaves, and there is a lot of chemicals associated with that, benzene specifically, and so that can cause fire hazards. If you're not locking up your gummies, you're also not locking up your bleach and your other sorts of chemicals, and kids will get a hold of that. Also, anytime there's drug use or drug sales in a household, violence goes with it, because drugs equal money. So anytime there's anything where money is exchanging hands, there is likely to be other sorts of criminal activity and violence happening. We see lots of times where kids are exposed to drugs that there are guns in the household, there are drugs laying around, there is criminal activity happening in the household around the children. So that can be really specifically problematic from their safety standpoint. One thing to keep in mind is that all forms of child maltreatment are like eggs and bacon. They go together. And welcome to my cat, who always likes to be on Zoom. Sorry. So if you have one form of child maltreatment in the household, so whether it's neglect or drug endangerment, there's likely to be other forms of child maltreatment in the household, like physical abuse, emotional abuse, those types of things. So how can we help these kids? Well, one, it's important for us to look for and respond to abuse in an effective manner. The first step is to know that it exists. People in our society don't want to recognize that abuse exists because it's an uncomfortable topic. So ignoring the fact that it exists does not help anybody, especially the kids that are involved in these households or the families, because really the goal of Child Protective Services is to make families healthier and safer and to keep them together. So recognizing abuse not only stops the abuse of the child, but allows for services to be put into place so that these families can be healthier and safer overall. When I talk to physicians, I have to explain to them that we need to assess for signs of abuse regardless of the presenting complaint, because people aren't going to come in and say, hey, I abused my kid today. They're going to come in for pneumonia or asthma or some other issue, and you need to be able to look for those signs of abuse so that you can recognize it. All professionals need to screen for stressors that may be risk factors for abuse when they're dealing with families, because this allows for mitigation of those risk factors and can help us prevent abuse from starting, or in the case of we have an index child, help prevent abuse to subsequent children in the home. Anytime you as a human witness acts that are concerning for possible abuse or neglect, you should report them. It's your duty as a human being, even if you're not named as a mandated reporter, because right now you're a student. At some point, you're probably going to be a mandated reporter, but just as humans in general, it takes a village to keep families and kids safe. So reporting those things is really the first step for us to keep kids safe. I want to briefly touch on sexual abuse, because there's a lot of barriers for us in recognition of sexual abuse at baseline that I think you should be aware of. When we talk about sexual abuse, most people think of kind of penetrative injury. So adult penetrating a child's vagina with their penis or their anus with their penis, but it can be any sexual act between an adult and a child. Doesn't matter the nature of that sexual act. When we talk about children in most states, it's an act between an adult and a child less than 14. They give caveats between 14 and 16 that it's sexual activity with a person over 18 and more than 4 years their senior. We use 4 years as a general age range when we talk about sexual abuse because people within 4 years of each other are within the same developmental stage. So if I have a 12-year-old and a 13-year-old acting out in a sexual way with each other, that's normative sexual behavior. If I have a 12-year-old acting out with a 5-year-old, that is not normative sexual behavior because the 12-year-old is engaging in this activity for a very different reason than that 5-year-old, and that makes it more of an abusive event. Anytime a sexual act is happening with a person who is mentally incapacitated or physically helpless, so we think of our intoxicated people, anybody who's unconscious, that is not consent. If you've ever seen the video Consent is Tea, it's one of my favorite videos. I give it to all of my teenagers. So helping people to understand what consent is and what consent isn't is really particularly helpful. Clearly, any sexual contact accomplished through force, threats of harm, manipulation, or coercion, regardless of the age of the persons involved, indicates rape. Rape is always a crime. Non-contact acts also are considered sexual abuse. From a criminal standpoint, we have to prove that the non-contact act is for the purpose of the sexual gratification of the perpetrator. So watching a child in states of undress because it turns me on, showing a child my genitals because it provides sexual gratification to me, or exposing children to sexual content. Anytime there's sexual exploitation of a child less than 18 years, that is abusive. That's what we call human trafficking. CSEC is the term that we use in medicine. So commercial sexual exploitation of children. In those cases, force, threats of force, or coercion do not need to be proven. When we talk about sexual abuse, we kind of separate it into assault and abuse. When we talk about sexual assault, by its very nature, that involves force and or physical violence. Almost never does it have physical examination findings, although if we're going to see them, it's usually because force is involved. This may not be disclosed by victims immediately, and it's most often perpetrated by someone known to the victim. So stranger rape is very, very, very uncommon. When we talk about child sexual abuse specifically, we know that this is usually recurrent and or prolonged. It almost never includes acts of violence. In those cases, it's most often grooming. So grooming of the child's body to allow them to break down those natural barriers between adult and child sexual activity, grooming of a family to allow ongoing unmitigated access to children, and grooming of the community at large so that if this child discloses abuse, no one's going to believe it because this is such a wonderful, upstanding person. Almost never does this result in any sort of physical examination findings. Disclosure is often significantly delayed. This was the basis of my research and an ongoing research interest of mine. And when you look at children who disclose in childhood specifically, on average, it takes them 2.4 years to disclose their abuse from the first abusive event. And that's just an average. We know that many children don't disclose their abuse in childhood at all, if ever, and many times they won't disclose until they're adults. So when I'm just talking about when we look at kids disclosing in childhood. Almost always the perpetrator is someone well-known and trusted by the victim. So how big is the problem of sexual abuse specifically? Well, when we look at prevalence, we know that about 1 in 3 females and 1 in 5 males will have some sort of unwanted sexual experience before age 16. So this is extraordinarily common. These numbers are similar to adult studies. When we look at adults and ask them about retrospective reports of child sexual abuse, they'll show rates of about 20 to 30% in females and 5 to 15% in males. I actually don't think it's less common in males. We just think that males are less likely to acknowledge their victimization and therefore less likely to disclose that victimization. When we talk about prevalence and the issues with prevalence, the biggest issues are that it requires 2 things. 1, it requires that you recognize that you are a victim. And two, it requires that you disclose your victimization, because sexual abuse is a largely hidden offense. Only two people know about it, the victim and the perpetrator. If you aren't, the perpetrator is certainly not going to tell that he's, diddling children or she's diddling children. So the way that we learn about this is when a child is brave enough to tell that it is happening. And I cannot stress this enough. This is the most difficult thing for a child to acknowledge and to disclose to adults. And it takes a really extreme amount of bravery. On the stand, the biggest defense is that kids lie. Do kids lie? Absolutely. Kids lie all of the time. Kids lie to get out of trouble or to prevent themselves from getting in trouble. Telling about your abuse creates a crap ton of trouble. So if I disclose abuse, a lot of really horrible things happen. CPS comes, law enforcement comes, people ask me repeatedly, am I telling the truth? I have to go see a doctor who looks at my genitals. I have to go testify against my perpetrator in court. My family gets mad at me. My siblings get mad at me. People are pressuring me to take it back. People are repeatedly calling me a liar. Bad things happen. The most common lie in sexual abuse is recantation. So a child makes a true disclosure of sexual abuse and subsequently recants that disclosure because all of these bad things happen. It is very common that people presume children are lying about this. But if you think about who has the impetus to lie in child sexual abuse cases, it's clearly not the child. Why? What does the child gain by saying that they're sexually abused? Absolutely nothing. It's a terrible, terrible experience. The perpetrator gains a whole bunch, right? They're not getting in trouble. So they're lying to protect themselves. And that's really the motivation for lying. So LLPOF, or liar, liar, pants on fire, is one of my favorite medical diagnoses. But when we look at the data on false allegations of child sexual abuse, it's about 1% to 2%, and kids are really terrible liars. So when they are making this up, we know why they're making it up. The one child I had that was blatantly lying was a teenager who was pregnant, and to hide her consensual sexual activity, she said that she was sexually assaulted. She couldn't maintain the lie. Kids are terrible liars. So it was very clear that she was not sexually assaulted. The most recent studies out of Colorado that look at false allegations of child sexual abuse show that the instigators of that false allegation is actually adults in their life and not the child themselves. The child will deny abuse repeatedly. Why do people not believe kids? Well, there's a couple of reasons. One, kids don't react the way we as adults think that they should. People expect that when bad things happen to children, they will tell somebody about it, and they just don't. We do a really good job as adults of teaching kids that if you're involved in something that is not good, you're going to get in trouble. So the number one reason kids give me as to why they didn't tell is that they were afraid they were going to get in trouble. So the way that we discipline children actually works against us when we're talking about helping children to disclose their abusive events. People also believe that victims are going to scream, fight, or otherwise alert people to the abuse, and that's just not true. It is not fight or flight. It's actually fight, flight, or freeze. And the overwhelming physiologic response to sexual trauma is to freeze. Kids don't yell, they don't scream, they don't fight. That does not mean that they are not victimized, and it does not make it their fault. So this is normal behavior. The other thing that's really problematic for adults is that children never tell their parents first, and parents will not believe children because they're like, I've always told her or him that if bad things happen, they should tell me. Well, kids just don't do that. Kids are smart. They know that this disclosure is going to make you feel bad, not even necessarily about them, but they will protect parents over choosing their own safety, and they will almost never tell parents first. Kids also disclose at unbelievable times, which makes their disclosure seem unreasonable to lay people. Children will often disclose when they feel that they're safe, such as when parents break up. So then it's thought to be, oh, this child is just vindictive and mad, and so they're making it up. And victims, especially teenagers, will disclose at times of intense emotion. This is called the pressure cooker effect. It's well described in the literature. So they'll be in some sort of verbal altercation with their parents because they're teenagers. And during that fight, they'll be like, well, you just don't understand because he keeps raping me, or something to that effect. And so then people don't believe that disclosure because they're like, oh, she was just angry. Well, really what happens is that intense emotion has been damped down by the victim for so long that it just kind of explodes out without volition. I had one child explain it to me. She said it was like a soda can shaking and shaking, and then the top just blew off. And that's such a good description of what happens to them. So anytime there's some sort of intense emotion, it just kind of flies out their mouth, even when they don't want it to. There's also this errant notion that I'm going to be able to look at a child's body and tell that sexual abuse has happened. And that's just not true. 90% of the cases of founded sexual abuse that happen, even when I have like pornographic images of it happening, or the child has a sexually transmitted infection or is pregnant, I cannot look at their body and tell that sexual abuse has happened. A lot of this is the virginity myth. So virginity is a cultural concept. It is not a medical concept. There's no cherry, nothing pops, nothing's different. There is always a hole there. The hymen is actually a stretchy ring of tissue at the entrance of the vagina. It stretches to allow humans to come out of there. And if humans can come out without causing permanent brain damage, it does cause permanent brain damage, clearly. Without causing permanent damage, smaller things than humans can go in without causing permanent damage. It's really funny because people are like, well, then why did I bleed the first time? Well, they did it wrong. So any body that's adequately prepared for sexual activity is not going to have injury. It's not going to have pain. It's not going to have bleeding. So perpetrators are very good at this. They do not injure children on purpose, because if you injure a child, you get found out, right? So they will groom this child's body at length so that no injury is found. The other issue that we see is people have this expectation of what perpetrators are going to look like. They think it's this creepy dude on the other side of the computer or driving the ice cream truck, and that's just not the case. This is your neighbor, this is your coach, this is your teacher, this is your pastor, this is your favorite sitcom actor who ends up being a creeper. But this is part of the grooming process. These are well-respected, well-liked people who place themselves in positions of authority in which they have a lot of respect, so that when children make disclosures, no one believes the child, because why would this wonderful person ever do these things? And so we as humans would rather believe any other scenario than this person that we like and we trust and we think of as a good human is potentially a perpetrator of terrible abuse of children. In actuality, anybody can be a perpetrator of abuse of children, and they often place themselves in these positions where they're well liked and well respected. So how can we help in reduction of sexual abuse of kids? Well, empowered kids are safe kids. So it's really important for us as a society to teach kids body safety, where people can and cannot touch them and under what circumstances. Giving kids correct names for body parts is also really important. These foo-foo names people give genitalia do not help when kids make disclosures. It also teaches kids that it's a secret, right? So you don't call your nose your tutu or your ear your pie. When we give code names to genitalia, all it teaches kids is this is something I cannot talk about, and perpetrators will use that to their advantage. So giving them the correct names is really important. It also garners a different response. So if Sally goes to her teacher and says, Joey touches my cookie, she's going to be like, your oatmeal raisin or your chocolate chip, as opposed to she goes to the teacher and says, Joey touches my vagina. That garners a very different protective response. It's also important for us to explain to kids the difference between okay secrets and not okay secrets. Anything that has to do with your body or your safety is not a secret that you get to keep. Even if the bad guy says you have to keep this secret or I'm going to kill you. Bad guys lie. That's what I told my kids. Bad guys lie. That is not a secret that you keep. It's also imperative for us to teach kids that we have to tell other people's secrets, because a lot of times children will disclose their abuse to other children, and those children really can't keep them safe. So the receivers of that information need to be empowered to go seek out an adult who can protect their friend. It's important for us to teach kids that their body is their own and they can control it. This is hard for us as adults and parents. I have parents who live on the other side of the country. When my kids were small, we would visit my parents maybe once a year. And my first response is, oh, go give Dee Dee and Pappy a hug and a kiss. My children don't know these people, right? Just because I have a personal relationship with these adults doesn't mean my children do. I cannot assume that they feel safe doing that. We cannot teach children that they should succumb or give their body over to a person just because they're an adult. If you do not feel like you want to give somebody a hug or a kiss, do not submit your body to them. There are other ways to show that you like somebody or care about them: high fives, fist bumps, all of those things that do not involve body touch. Teaching children that it's okay to tell any person no to an unwanted or uncomfortable touch is important. And uncomfortable not necessarily being painful, because abuse often doesn't hurt. Oftentimes it feels good, especially for boys. You touch their genitals, they get an erection, and it feels good, which is why it's very difficult for children to recognize their victimization when it doesn't feel bad, because we teach children, tell if somebody hurts your body, right? If you're not hurt, it still may be uncomfortable in an emotionally uncomfortable way. We also need to give kids a plan, help them to identify adults who they can tell if something is uncomfortable, and this should include persons outside of the family. Remind children that if they're not believed by that person they tell, to keep telling until somebody believes them and somebody does something about it. We need to provide these messages early and remind kids often so that we can enable them to make these disclosures sooner, because it will stop their abuse and prevent other kids from getting abused. We know that for every one child who discloses sexual victimization, there are at least 20 other victims of that perpetrator. So teaching children to disclose not only helps that child, it also helps other children to be safe. So that is my spiel. Everything I've learned in 10 years about abuse, in overtime probably. Does anybody have any questions? I really appreciate you guys paying attention for that long.
Thank you so much again for that. That's really, really great. I know I said, I know some of you had other classes and stuff to get to, so feel free to do that. You can also email me if you have any follow-up questions, but does anyone have any questions right now before we let Dr. Nino get on with her day?
I have a question.
Yeah, Claire.
You mentioned like previously in the beginning, ways that like psychological trauma can like manifest physically. What are like really common ways of that, or like telltale signs? Like what does that usually look like?
Good question. So what's interesting is most kids who are being abused they accommodate to their abuse, meaning they don't have telltale signs of abuse, which is one of the reasons why we don't do a good job of recognizing it. Those telltale signs don't tend to come out for many, many years. So when we see kids who are acting out because of their abuse, sometimes that can be aggression. So if I'm like physically abusing my children, what does that teach my children? That teaches them that when I'm mad at somebody, I hurt them, right? So then these kids will hit other kids when they're mad. When we talk about sexual abuse specifically, it can be new onset bedwetting. It can be specific fears. It can be nightmares. It can be cutting. I would say 99% of my teenage sexual abuse victims cut. That doesn't mean that all cutters are sexually abused, but in my population of abused kids, they almost always cut because they don't know what to do with their emotions. And so it helps them release emotions. Little kids don't tend to have these issues, which is part of the problem. When we recognize abuse, we tell parents, hey, you got to get this kid some therapy. And they're like, oh, well, they're fine. Well, they may be fine now, but they're not going to be fine later. What's interesting is that stress in general will cause physical responses to kids. So kids are a little bit spectrum-y in that they don't like change in their environment. So anytime there's a change in environment, new sibling, new boyfriend, divorce, change in schools, kids will often manifest in physical ways. Tummy aches being really one of the most significant ones. Kids will complain about perpetual stomach aches, headaches, those types of things. And that just means stress is happening. So what's important is if we don't know of any other stressor, abuse has to be on the list of the stressors. But as far as telltale, there's nothing that's like pathognomonic. That's our medical term. That means it's definitively this. It's just anytime we see stress responses in kids. Really good question. Any other questions?
Other questions?
Thank you guys so
More?
much for your
Oh, you're
time. I
welcome.
really appreciate it. Good luck with the rest of the school year. And if any questions come up at any point, send your questions to Dr. Posick and I'm
Mhm.
happy to answer them.
Claire, did you have one more?
Yeah, I did.
Oh, sorry,
actually.
Claire.
I wanted to ask, as someone who like works like day to day, hands on with young victims, what is like some advice you'd give to someone else who like also thinks that they might want to work with like victims who are children, like 'cause that can be like, I feel like emotionally tolling as a job. Do you have any advice?
Yeah. So you have to have good self-care in place because what we tend to do is compartmentalize. Like I've got this little box and everything goes in my box and it's all fine until the top flies off and then I'm a wreck because you're fine, you're fine, you're fine, and then you're not fine. So having a plan for self-care in advance is really important because you're not going to recognize you're not okay until you're really not okay. I have a really good therapist and SSRIs because you take on secondary trauma. I have a lot of secondary trauma from the things that kids tell me more than what I see, which is
Mhm.
interesting. But it is super rewarding. I would not want to do any other job. And if the only thing I do in life is to help a kid understand it's not their fault and I believe them, then I have done my job. And really, that's all I want to do is like empower these kids that this is not your fault because every kid will blame themselves for their victimization inevitably. But
Mhm.
good self-care, that's all I can say. Really good self-care.
Thank you.
You're welcome.
Thanks again.
Sure.
And
Thank you.
we'll be in touch soon. If there's any other questions, I'll send them by email to you.
Okay, great. Thanks. Sorry I
Alright.
went over.
Oh, fine.
Bye.
Take care, everybody. Have a great weekend.